This right here is what we're going to talk about today. These are exosomes. These are exosomes as viewed on a very expensive $150,000 microscope I had to buy to be sure that I had exosomes. This is on a nanosite. So these particles are 100 nanometers in size, and they're the size of a virus. So in 2014, when I started telling people exosomes, I wasn't absolutely positive I had exosomes, just like a lot of people that are selling exosomes now. But I was doing it by protein concentration. And then when I finally got this and I saw that day, I was very excited that I had actually been selling exosomes this entire time. So to address what was just asked over there, I was like, why not just use fat? There's more stem cells there. Well, first of all, there's not that many stem cells. And second of all, you're missing the point, which was mentioned. Bone marrow is functional because it has many types of cells in it, mostly anti-inflammatory, because it has to protect the hematopoietic stem cell. So there are myeloid-derived suppressor cells, there are regulatory T cells in very high concentrations, there are of course MSCs, but I will argue that when you use adult cells, it's really not the MSCs that are having the anti-pain function, it's the anti-inflammatory milieu that's there, and that can come from anything in bone marrow. In fat, you really don't have that anti-inflammatory milieu. You do have a structural milieu, you have MSCs, and if you really want to know exactly how many, in 60 cc's of fat, there's 150,000 MSCs. In 60 cc's of bone marrow, which a lot of that is blood, there's 50,000 MSCs. And I'm saying that because I ran it myself on a flow cytometer, and I've had other independent third parties tell me the same thing. So why do I like bone marrow so much? Well, I've been thinking about it for 20 years now. My father was diagnosed with AML in 2000, and I had to go through the PhD program in biochemistry and immunology at the University of Miami to get where we are today. So I spent a long time in school, and I know a lot about bone marrow transplantation, both positive and negative. I'm also the founder of Kimera Labs, which is an exosome producer. And what I just said to you about bone marrow, I mean, how do I know that? I know that because we have now 70 ongoing years of experience with bone marrow in the hem-onc world, and we know quite a lot of things. We know the markers, we know the proteins that are most important, we know the rejection rates, and these things are very clear. So when we talk about bone marrow transplantation today, let's talk about aspiration of bone marrow from the bone. But of course, there are other ways to do it. You could mobilize stem cells to the blood using Neupogen and other factors. So these are my poor babies, you know, that I've gone through thousands of them. And this is a model of bone marrow transplantation that I worked with. This is HLA-matched bone marrow transplantation, even though these mice look different. They're genetically modified. But although they are HLA-matched, they are still minor mismatch. Even the protein that makes that mouse brown will make these mice reject the other cells in a period of 18 hours. And that's HLA matched. The reason I'm showing this to you is that when we talk about cord blood transplantation for orthopedics and such like that, those cells don't persist for very long at all. I'm saying less than 24 hours. And to prove that in this flow cytometry here, you can see if you take splenocytes and put it into a mouse, 3 days later, if it's a twin, you can still find the cells. But 3 days later, if it's not a twin, you can't find the cells. So that's kind of showing you there that the cells are very rapidly rejected, and I've done this thousands of times. I'm not questioning it anymore. So in graft versus host disease with mice, we have a very nice model of inflammation. Graft versus host disease is the worst inflammation you can think of. And these poor mice get fibrotic, etc. They lose weight and they die after a period of time after doing that HLA-matched transplant. So that just shows you how quickly minor antigens can cause rejection. One of my goals was to suppress graft versus host disease, suppress inflammation. And the best cell that I could find to do that is a regulatory T cell, not an MSC, a regulatory T cell. So if I wanted to talk to you about making exosomes, and I really wanted to make the best anti-inflammatory exosome I could, I would make it from a regulatory T cell, because every cell expresses or excretes exosomes. But since regulatory T cells are very difficult to culture, they don't attach to plastic and it's very difficult to isolate them and grow them, I decided after leaving the University of Miami that I would concentrate my laboratory on mesenchymal stem cells. MSCs are like my slightly weaker replacement for regulatory T cells. But they also have some benefits over regulatory T cells. We know that they instantiate growth through things like hepatocyte growth factor, fibroblast growth factor, IGF. And they have my favorite anti-inflammatory proteins, IL-10 and TGF-beta-3. TGF-beta-3 is like the holy grail of anti-inflammatory factors in the immunology world, because just taking TGF-beta-3 and putting it in vitro in a dish with an activated CD4 T cell, you will deactivate that CD4 T cell and turn it into a regulatory T cell. And that's a permanent conversion until some other inflammatory insult comes along. So this is what an MSC looks like. What is it doing? It's sitting on the vasculature. Well, how does that help? I mean, what I want you to think of from now on is that the MSC is like the center of the body, like we used to think of the heart. And this cell has nothing to do besides control the growth of the cells in the rest of the body. When a child is growing, a liver cell doesn't care what the kidney cell is doing, but something is telling those cells to grow. It's the MSCs in the environment excreting exosomes into the circulation that are telling the entire organism to grow. So knowing that I could suppress graft versus host disease with regulatory T cells, and if you look at the major transplant centers in the United States, they're still all trying to use regulatory T cells to suppress. This company, Mesoblast, was using MSCs, and they could suppress, in the majority of the time, chronic graft versus host disease using 14 million allogeneic MSCs in a 70-kilogram adult. So when I saw this, now I had a number, I had a target. So for the worst inflammation I can think of, I need 14 million MSCs. I just told you there are 50,000 MSCs in bone marrow, right? So we had a long way to go. So I thought my job was going to be working with providers to help you really isolate stromal vascular fraction correctly and use that in treatment. And in fact, I had an IRB for the treatment of COPD and treated a lot of patients with that. I found that the results, while encouraging 40 to 60% of the time, most of the time the patients relapsed. So, you know, I don't have the heart to ask people for that much money repeatedly. So I said, okay, well, I know that 14 million will suppress chronic graft versus host disease. I've got to get a lot more cells. Let me start expanding their cells. So I started expanding the patient's cells to 7 million. That was my target number because, you know, COPD is not quite as bad as graft versus host disease. And so with 7 million cells, the efficacy rate went up to about 60 to 80%, which was very encouraging. But at the same time, they would still relapse. And so I would have, say, a really wealthy patient that I could improve his scores, you know, 3 times in a row. By the 4th time, I couldn't help him anymore. And then I would have 90-year-old patients that I would feel bad for the family, and I would throw the kitchen sink at this guy. I would give him 100 million cells, and nothing would happen with his own autologous cells. And so, I mean, I was really not understanding. So one day I had, when I was growing these cells in my laboratory, I had an 18-year-old paraplegic cells and a 70-year-old COPD cells. The 70-year-old woman was the wife of the surgeon that I was working with. So if I didn't get her cells to grow, I was going to have a hard time convincing him that we were going to make a business out of this. They had to grow. And so I did everything to try to get these cells to grow. I changed oxygen concentrations, I changed mediums, I put different types of growth factors. Nothing would work. So I started thinking, well, you know, there's the paracrine effect. You know, the word paracrine doesn't mean anything to me. I mean, we know what it means, but it's not something that you can really hold on to, right? It's proteins, supposedly, right? That's what we think of paracrine effect. I thought the paracrine effect was. Well, when I was in the biochemistry department, I would express recombinant proteins. And these proteins were so difficult to assay that the second I produced them, I had to run to the bench to run the assay to see whether or not they were functional or not. I was working on enzyme kinases. And so knowing how labile proteins were, it was impossible for me to believe that the body is really run by growth factors running through the circulation, not getting eaten up by proteases, and not denaturing just from the 37 degrees Celsius heat that is present. So I said, well, I don't really have a choice. Let me just take the supernatant from the 18-year-old cells, put them on the 7-year-old cells, and see what happens. And now the bright side was that I was looking at these cells very carefully so I could tell if there was any kind of change or movement. So the 7-year-old cells started growing. And right away I was like, oh my gosh, you know, paracrine effect is real. You know, this is something I can control. I don't need the cells to make cells grow. I just need the factors. And knowing how easy it is to manipulate factors, is when I stopped using cells. And since I'd started doing that, I would say the efficacy rate has gone up to 90–95%. So the reason I've never worked with third-party cells, like I told you, is because of their rate of rejection. And this is a better way to think about it. People always say, well, MSCs, they're immune privileged. I mean, this is nature, right? Well, in fact, they're not immune privileged, they're immune evasive. And they're immune evasive because they don't have MHC class II on their cell surface, so they do persist a little bit longer. If you throw a dendritic cell into somebody, it'll be rejected much faster. So when I was trying to figure out this number of cells, I knew that there was a dose escalation response to using more MSCs, and that had been shown in wound healing. If you add more MSCs to a wound, the wound will close faster and more extensively. The problem with cells are that the persistence is limited to days. I said 1 day in the case of allogeneic, but imagine pulling a cell out of its niche in the fat, putting it on top of a burn. That cell now has no vasculature. It's going to die within a couple of days if it doesn't get some arteries and veins running by it. So you've got that problem. Second of all, if a burn victim comes in, you don't have time to grow their cells. It's going to take you, it takes me about 6 weeks to grow cells straight out of stromal vascular fraction. As I said, third-party cells will be rejected, and allogeneic cells are not approved. They are a 351 product, as was mentioned before. This is from the FDA website, right? Unrelated allogeneic hematopoietic stem cells, which is what cord blood is, have always been a 351 product that you need a BLA for. I could never quite understand where this whole regenerative medicine, let's use cord blood business came from, because it's always not been legal, right? It is legal if you're related to the umbilical cord blood donor. Other things that are allowed as a 361 product are cartilage, amnion, that's fine, right? Here we've got pericardium, skin, the typical things you might take from a cadaver. That is absolutely a 361 product. So what does that make cell secretions? Well, this is from the November 2017 guidance that was just mentioned, and what we are allowed to do right this second. It says here, secreted body fluids, amniotic fluid, are generally not considered HCTP. They're not even a 351 or a 361. Amniotic fluid is nothing. I couldn't even register for it this year on my FDA tissue bank registration. The cells that are in that amniotic fluid are considered HCTPs, and they're 351 HCTPs. It also states that the following article is not considered HCTPs. Secreted or extracted human products such as milk, milk contains exosomes, collagen, and cell factors. Secreted cell factors are not regulated. Now, why do I know that this is real? Because exactly a week before this came out, the FDA inspected me. And they asked me very pointed and repeated questions about whether or not I had any cells in my product. And I was very happy to show them my literature saying my whole company is based on not needing the cells. So they left, and I didn't get a letter, and I haven't heard from them since. So the FDA has my entire process that we're going to look at now. I didn't say anything, so let's just knock on wood and leave it at that. Right? So in the past couple of years, there's been this exosome explosion. Like more and more people are saying they have exosomes, and everybody wants to talk about exosomes. So what are they? They're 100 nanometer lipid vesicles that are protecting those proteins that I told you are so labile, and I couldn't understand how they got around. They get around because they don't have access to proteases because they're surrounded by a lipid membrane. They also protect messenger RNA, and that's going to be very important. I'll get back to that in a minute. This is what an exosome looks like budding off of a cell. And where can we find exosomes? We can find exosomes in blood. We can find exosomes in urine, amniotic fluid, milk, and cell culture conditioned medium like I'm going to discuss. It's interesting to think that when you're drinking cow milk, you're drinking cow exosomes, and then you're expressing cow proteins for a period of up to a month. It's a very nice thought process. So this is a typical way to make a purified exosome. This is how you do it in the laboratory, such as I do it. You take a placenta. I think of the placenta as the olive tree. I grow the olives, and then I isolate the olive oil. It's extra virgin olive oil in this case, because it comes from placenta. So when you grow those cells, you have an opportunity to tune the growth of those cells. You can either use low oxygen, you can stress the cells, you can change the growth factor mediums that are in there. And in fact, I have 9 different types of exosomes. Right now we're going to talk about MSC exosomes, but I have oligodendrocyte, precursor cell exosomes, chondrocyte exosomes, fetal bone marrow exosomes. I mean, every tissue MSC has a different secretory profile. A regulatory T cell exosome is going to look different than an MSC exosome. There's a really unlimited number of types of exosomes you can have. But for the sake of production at the level that I have to produce now and the FDA, we concentrate on this one specific formula of exosomes for right now. So when you expand those cells, you've got your cells and you've got your exosomes in culture. That's now conditioned medium. And conditioned medium consists of debris, exosomes, and cells. So the first step is to remove all the extraneous cells and debris, and so you would sterile filter the products. Now you've got, as opposed to cord blood, which is collected in a surgical suite, which is not really sterile, especially if you were trying to culture cells. Now you have a sterile product. At this point, you still have the sterile product in conditioned medium, and conditioned medium is definitely a drug. There's dexamethasone in there, there's recombinant proteins, all types of things in there. You can't sell conditioned medium. And it's not just the cell secretion. So you have to remove that conditioned medium. And the way to do that in the literature is to spin the product down at 100,000 G, which is a very robust centrifuge. It's very scary. And if it breaks, if the rotor comes off, it's going to go through the ceiling. That's how fast it's going. So, but by spinning that fast, you can get these tiny little viral particles to sediment. Then you can remove the conditioned medium. And then you have to resuspend the product in saline or something. You know, it could be PBS, it could be whatever you want. But then you have what should be termed an exosome because it's purified. Before you purified the exosome, you had conditioned medium. I hope that's clear. Then you can quarantine the product, test it for growth factors, and release it as we do. So, you know, being able to get ahead of production to have a product that you can test before releasing it is actually really difficult. So, but now, everyone in the world has an exosome product. One of the ones that kind of irks me most is an amniotic fluid exosome. So let's explain that. So whole amniotic fluid contains epithelial cells, not stem cells, vernix, meconium, and it does have exosomes in it. The fluid can be spun down in a regular centrifuge like you all have in your office, and then you can remove the cells that way, and the amniotic fluid and the exosomes will stay in the supernatant. You can then sterile filter it. I mean, it's not easy, but you can do it. And I do actually have a product like that. I'm going to tell you why, and I like it. I just always call it amniotic fluid. The epithelial cell-derived exosomes cannot be purified because there's all this other stuff floating around in the amniotic fluid, like the meconium, like other types of small debris. So it's really, if I knew how to isolate exosomes from amniotic fluid, I would do it. But the amniotic fluid itself is going to clog everything up. So I just would like everybody to understand and call things as they are. If it's milk and it has exosomes in it, you still have to sell it as milk. And what I really am afraid of is Dr. Spiel will tell you his protocols. If you use milk in his protocols, you're going to be in a lot of trouble. Okay? And I really don't want anybody coming back to me on that. Okay? I like this one right here. It's like, you got some exosomes? All right, so what do exosomes have in them? They have messenger RNA, microRNA, and protein. What you have to understand is I've mentioned a bunch of different cell types and that exosomes can come from them. Think of the exosome as his helmet. You want this exosome over here. You don't want this exosome over here. They both play football, and one might have a better running game than the other, but you have to understand that. But we can't use the word exosomes. It's too broad. It's like saying fruit. There's apples and oranges. So the way the exosome communication works is, and the way I now understand that cell signaling or human signaling works is, the cell that's trying to tell the other cell something secretes an exosome with messages in it. When it gets to that new cell, the one messenger RNA that's in the exosome can now produce thousands and thousands of proteins. The half-life of the VEGF protein is 4 hours. The half-life of the VEGF messenger RNA is 4 days. And if you've ever seen a video of a ribosome running down a messenger RNA, it's fast, and there's multiple on there at the same time. I mean, it's way more than thousands of proteins. It's probably billions of proteins over the period of four days. That's why every type of TNF-alpha or protein-based cancer therapy has not worked, because the protein actually breaks down before it can get there. What we should have been doing is providing the message for the TNF-alpha and providing that in a lipid vesicle and allowing that to create a more inflammatory state in the human. So you also have microRNAs that can control the expression of other messenger RNAs, and of course you do have some protein. But like I'm saying, the proteins don't get far. What you need to do is make the protein in the environment where you need the effect to occur. So if you put exosomes in a dish with marrow epithelial cells here, they'll be taken up in a period of 3 to 4 hours without you having to do anything else, okay? So the opportunity or the benefit of exosomes over cells is that I've never had a non-sterile product. I can absolutely assure you that when I run a conditioned medium through a sterile filter inside of an ISO 5 hood, inside of an ISO 7 room that my staff had to gown up to get into, and they washed their hands for an hour before they went in there, it's really hard to contaminate this, okay? It's easy to test it for sterility, and I test it to endotoxin levels down required for intrathecal administration. I've never not passed any of these tests. It can be concentrated, which is really valuable, right? It's not going to be rejected by a third party because there's very little, if any, HLA on the surface of an MSC exosome. If it were a dendritic cell exosome, it might have more HLA and HLA class 2. So again, it's really important to specify the cell that the exosome is coming from. And they can be frozen, not cryopreserved. You cryopreserve a cell or a liquid with cells in it so that you can maintain the viability of the cell. If we don't have cells, we don't need DMSO. If you don't have DMSO, you don't get sulfur reactions. You can freeze these. I freeze them at -80, but you can keep them in a regular -20 freezer on top of your refrigerator for a period of up to 6 months. So it makes life really easy. At -80, you could keep them for a year in liquid nitrogen. They'd be forever, but a cell is pretty much forever in liquid nitrogen as well. So these are some of the earlier experiments showing that conditioned medium was as functional as cells in a condition of emphysema here. This is a control. So we can see that it's really the paracrine effect, the secretory milieu of the MSCs, which was mentioned in the previous talk, that is really doing the work here. So one of the other benefits is when I showed you that wound healing assay where you would put the cells on the surface of the wound, let's pretend, I'm being generous here, that those cells persisted for 7 days. It's very easy to keep that same cell growing in the laboratory for 25 days, collect all the exosomes, concentrate them down into 5 cc's and give them to you like that. It seems like a lot, more intelligent approach than hoping that a cell is going to persist where you put it. So this shows that MSC exosomes are responsible for angiogenesis. And here is an example of a chondral defect created in a rabbit, which is being cured with exosomes in a matrix. So Dr. Spiel likes to use PRP combined with exosomes. I don't care what kind of matrix you use, and I'm working on a specific one for use on exosome matrix. But you definitely need a matrix in many cases. You need to keep the exosomes where they need to go. In this case, they use something pretty cool. It's a hyaluronic acid UV stabilized gel. But in this assay, there are no cells. There's only the gel and exosomes. And the cells migrate out of the periphery and into the defect to cure it. And here, right here, this is exosomes alone, so you don't cure the defect. But when you put exosomes in a gel, you do cure the defect in a chondral defect model. Now, if you were trying to do something else, you might not want a matrix, but again, that's up to you. And in fact, bone marrow is a matrix. I told you I love bone marrow. This is an example of a hip. This is 10 weeks out using bone marrow and exosomes. So the matrix is important. It can be whatever you want. It can be bone marrow. It can be fat. It can be micronized fat. It can be PRP. PRFM is actually my preferred PRFM. Whatever you want to do, you need a structure for the cells to hold on to. So this happened. I told you that story of the 70-year-old patient whose cells wouldn't grow. I realized right at that moment that I had been throwing out the good stuff for years. And the medium that I use is $500 a vial. And at the time, I didn't have a lot of money. It was very upsetting that I had thrown out all this good stuff for such a long time. So I started saving all the leftover conditioned medium from the cells that I was growing. And I was at a party on Halloween in 2014, and my friend threw water on a gasoline fire, and the party was very abruptly over. And the next morning, he's crying to me because he's afraid that his face is going to scar forever. And he is black, so there could be some scarring issues here. But I was able to convince him, and more importantly, his plastic surgeon friend who wanted to treat him with PRP that would have caused inflammation that would have been very bad in this case. I got some literature, convinced the doc, and he allowed me to spray those exosomes on his face 3 times a day for 7 days. This is 7 days later, and this is 6 months later. What I want you to look at here is the quality of the new skin. This is 53-year-old skin. That is baby skin. That's placental derived, exosome manipulated growth factors. That's 30 types of collagen as opposed to 8 types of collagen there. And that's really what's going on. I told you that I think the MSC is the center of the body. It controls the growth of the body. But when we're 20, we stop growing. So MSCs from a 70-year-old adult are not going to cause anything to grow. They are going to stop pain in, say, in a case of osteoarthritis, and the Mayo Clinic demonstrated that. They took bone marrow, put it in one knee, not the other knee. Both knees had sort of 9 out of 10 pain. And both knees got better just by putting the bone marrow in one knee. Like, how is that possible? Well, because I told you bone marrow is anti-inflammatory. So by stopping the inflammation, you stop the pain. But you're not going to cause an instantiation of growth or real repair. So MSC, children's MSCs are secreting about 300 growth factors. Our secreting are about 100. And that's really the issue, is that our cells are still anti-inflammatory, but they don't cause growth. So the secret is in the growth factors. So this here is a growth factor panel of amniotic fluid exosomes that we produce versus those purified exosomes that we produce. And this is like tea leaves to me. I, a long time ago, stopped worrying about what was best. All I care about is what growth factors are there. Based on these growth factors, I can tell you exactly what's going to happen. I can tell you that in the amniotic fluid, there's TGF-beta1, so there's going to be collagen deposition. This is what we need for cartilage. But I can also tell you that there's no TGF-beta3 in amniotic fluid. There is quite a bit of TGF-beta3 in the isolated MSC exosomes. There's no TGF-beta1. But if I want to permanently stop inflammation, I want TGF-beta3. If you look up hair regeneration, you're going to find stem cell factor. Not much stem cell factor in amniotic fluid, but quite a bit in the isolated exosomes. Amniotic fluid, we know, though, is anti-inflammatory, right? We see the response. Well, that's because we have IL-1 receptor in amniotic fluid, and we have TNF receptor in amniotic fluid, binding up all the inflammatory cytokines in the milieu. So I would argue that for a knee, the actual gold standard, and this is the way Dr. Spiel does it, is PRFM, or PRP, plus amnio, plus isolated exosomes. You want everything in that case. And when I look at this, because these exosomes are derived from amniotic epithelial cells, this looks just like PRP to me. It's like anti-inflammatory PRP. So, I mean, that's why I have it. I think it's fantastic. I don't think it's isolated. I think it's a little dirty, but for a knee, that's fine. You also see everybody likes to talk about tissue inhibitor of matrix metalloproteases. There's quite a bit more in the MSC exosomes than in the epithelial cell exosomes from the amniotic fluid. So all you have to do is go through this growth factor panel. You don't know a growth factor, look it up, and it'll tell you exactly what the two things are going to do. And that's what we see. If you put PRP and exosomes alone in a knee, there's pain from the PRP. If you put PRP with amnio plus exosomes in the knee, there's no pain. You know? So one is temporarily anti-inflammatory, one is permanently anti-inflammatory. Now, to back that up, I've also done messenger and microRNA sequencing of the exosomes, and I do see it correlate with what's going on here. And then Dr. Spiel told you yesterday that when you look at the IGF binding protein, you see why growth is instantiated. Whatever IGF is there is being maintained and persisting because of the addition of that binding protein. We also see, for many of you that have done regenerative medicine, you'll always see these patients that don't immediately respond, but they do respond 8 months later. And I even saw that at Toby. I mean, I've heard this from everybody. I've seen it myself. What's going on there? Well, if it's really regenerative, to expect that it's going to regenerate in days is not correct, right? If we're changing the epigenetic methylation status of a cell, making it younger, it needs time to be younger. It needs time to regenerate. So that, therefore, you know, because the nice part about sequencing is I could just ask my PhD, can you look up the telomerases for me, see if we have any telomerases? Can you see if we have any histone acetyltransferases or methylases? And he can just go back and find them. Boom, 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 boom. They're all there. So what these cells are doing is they're acting young. They're acting like a young cell. And that's everything that a young cell means. And I haven't even thought about what all those things are yet. For instance, if I've been saying to you that we have VEGF, we cause angiogenesis, we cause growth, we're anti-inflammatory, that sounds terrible for cancer, doesn't it? Well, I mean, I'd already been thinking about exosomes for a long time, I was very excited about it, and then I started seeing this kind of work, and I actually met some scientists doing this work. If you take umbilical cord MSC exosomes, and you drip them in a dish with a myeloid tumor that's proliferating, that tumor will stop proliferating. And the reason it stops proliferating is because the young cells are expressing the tumor suppressors that might have been turned off in that tumor. So just by expressing P53 and P10, for instance, in pancreatic cancer, most of the time it's a P53 or P10 non-expression that's causing the tumor. If you just replace the messenger RNA, you can now express those tumor suppressors, the cells stop growing. So that's fantastic. I'm not saying that you should treat patients with cancer for exosomes. I mean, you need to do a lot more work. You need to know absolutely the sequence of the tumor, what it's expressing, and then try to extrapolate whether or not you would think it would work, and that's down the road. The point is, they're not going to cause cancer in someone who doesn't have cancer. So that's the tumor take-home. They could actually be very beneficial. This is for you guys, a little clinical thing. We have seen all types of hair regrowth. The most impressive hair regrowth I've seen is in females with autoimmune alopecia. I saw some pictures from a provider the other day. It was something like 5 weeks and her whole hair had regrown. So that's one where I really think these exosomes are going to be functional. Androgenic, I'm not completely convinced about yet. So future directions are we're working with Dr. Shelley Jordan here to do file an IND application for craniofacial neuralgia using exosomes and targeted focused ultrasound. We'll slowly start rolling out the tuned exosomes, chondrocyte-specific, extra anti-inflammatory. We have, and I have IP on microRNA-specific exosomes that express higher levels of different mRNAs. And of course, I can genetically modify the cells to do all kinds of things going forward. So this is the laboratory. I'm very proud to have this beautiful group now. And if you want to come to the lab, you're welcome to visit.